Buenas tardes.
Good morning or good afternoon, everyone. I'm Carla Sainz, Regional Bioethics Advisor for the Pan American Health Organization's Regional Bioethics Program, which is part of the health and services at PAHO. Before we begin our session, I would like to go over some housekeeping messages so that you can access simultaneous interpretation if you need it. You will see there's a globe at the bottom of your screen that says interpretation. So if you, that's on the bottom right hand side of your screen. So if you click on the globe, you can pick your preferred language for the session. If you understand both English and Spanish, you can just leave interpretation off. Now, if you want to choose a preferred language, you can choose that language and also select the option that says mute original audio. Why? Because however even if this session is very interesting, I doubt that you want to hear to the presentation on both languages at once. So we kindly request that you select those settings now and to keep them throughout the session. I know that we have some panelists that will be speaking in English and some others, I'm sorry, most will speak Spanish and there's one panelist that will speak in English and the moderation will be in general in Spanish. I understand that everybody can hear just fine. So with that, I would like to thank you for joining us today in this third dialogue on ethics research during the pandemic, challenges and lessons learned in Latin America and the Caribbean. During today's session, we will focus on the perspective from our ethics committee members. You must remember that in a previous session, we had some members from the ethics committee present, but not all of them. But now we have a series of members, like I said, and the idea is for them to share with us their opinion or their reflections from the point of view of someone that is present in these discussions in a committee and that goes over protocols and is in discussions with others to make sure that these research protocols are ethics-based. The topic that we will be addressing today is challenges in these research, especially in terms of the social and scientific value as well as informed consent. We have picked these topics because, especially when we talk about informed consent, is something that the participants during our series of dialogues have mentioned several times as something that they would like to discuss further. And also, the issue of social and scientific value is very important because that has already come up in our previous dialogues as a very important topic again, mostly because we know that in this context of this COVID pandemic, the large majority of research that is taking place poses some specific challenges. I would like to begin by sharing some data that we did together with Sarah, Anna, and other colleagues such as Marcy, Neil, Rebecca, and Jacinta Hassans Remier about the different clinical trials for COVID-19 that we see in the region.
Como un telón de
This
fondo.
is just some sort of background for the discussions we're going to have today. So to make things a little bit easier, let me share my screen with you to show you some of the most important data coming from these research studies. So we went to the ICTRP platform that WHO has, and this is data as of August 19th on all the clinical trials for COVID-19 for Latin America and the Caribbean. So you can see on the right-hand side that the countries that have done the largest number of research studies, or at least that have recorded the highest number of research studies on this platform, or the records that feed into this platform, are Brazil, Mexico, and Argentina, followed by Colombia, Cuba, Peru, and Chile. 285 out of over the 5,200 from entries in this registry come from Latin America and the Caribbean. 206 are intervention studies. 170 have to do with products to treat or prevent COVID. 18% of those studies are multi-centric, and this is important because all multi-centric or multi-center studies have to do with cooperation with countries outside the region. These are not multi-center research studies with other countries. Also, 78% of the clinical trials that are not multi-country, but rather single country, do not have a business sponsor. Therefore, they're using their own domestic institutional resources. And even though this is a registry of clinical trials, we know that it's not all clinical trials that we have here. But as far as clinical trials go, we know that 141 are randomized trials, and 104 out of these trials have a sample size lower than 200. So what I want to highlight with this is that we see a lot of trials that focus on the same type of intervention, even within the same country. Just as an example, we can see that there are 27, or there were, this is back in August, there were 27 plasma trials in a single country, what I called single country trials a little bit ago. But in Mexico, for example, 7 out of those 27 clinical trials are taking place, and all 7 have 281 participants total. We knew that back then there were 26 trials on hydroxychloroquine and chloroquine, and 14 of those were in Brazil. This is just a slide to show you the clinical trials by type of intervention. And you can see that there are several that focus on the same thing, on plasma, antimalarial, certain antiviral combinations and antivirals, etc. So anyway, this is some information that I wanted to share with you because I believe is relevant as a background for today's discussion. Now, before introducing our panelists, I wanted to make 2 or maybe 3 announcements. The first one, as you know, this is the 3rd dialogue out of 6 regional dialogues that we will have on issues related to research ethics. The next one will be on November 24th, and we will have researchers with us. We believe it's extremely important to have this overall outlook, which is what PAHO constantly promotes. So we believe that it's very important to have researchers' point of view and hear about their reflections as well. That's the first announcement. Second is that you will see that yesterday PAHO published guidelines for supervising ongoing research studies on COVID-19 in light of new evidence. Now, some of our panelists were kind enough to provide support in reviewing this document, and thank you so much for that. And I will make the link available in a few minutes. And my third and final announcement is that for those of you who are not part of this to join the list of ethical research at PAHO, because through that listing, we we share these resources and training opportunities for the region. And without further ado, I would like to now introduce our panelists. It is a pleasure to have Sergio Zurugi de Siqueira among us. Sergio is a great collaborator from PAHO for our regional bioethics program. He plays a key role in the Proethos project. He's also a professor at the Pontifical University of Paraná in Brazil, but he's joining us today as CONEP member. And CONEP is the National Research Ethics Commission in Brazil. So thank you, Sergio. We're also joined by Sofia Salas, who's here as member of the Ethic and Scientific Committee for the Universidad de Desarrollo from Chile. She works on ethics and research topics as part of the bioethics program from the School of Medicine, the University of Desarrollo from Chile. But I would like to highlight that this is a collaborating bioethics center for PAHO and WHO. So thank you so much, Sofia, for joining us. We're also joined by Leonardo Perez. Leo is here as a member of this ethics committee from the Ramos Mejia Hospital in the city of Buenos Aires, Argentina. And Leonardo and I have been working on a lot of topics related to community engagement, and from PAHO trying to join efforts with him and the agencies that he works with in order to make tools available for the region to allow for better understanding in research and to achieve a fruitful dialogue and good listening practices as well, because that's key in order to achieve community engagement in these COVID-19 trials. And we're also joined from Trinidad and Tobago, Magda Bash, who is part of two ethics committees, actually. The ethics committee from the regional health authority from the Northeast in Trinidad and Tobago. The health system in Trinidad and Tobago is split into regions, so she is charged with, or rather she is representing the Northwest region, and she's also a member of the Southern Caribbean University, and more specifically the Ethics Committee. Magda and I have been working together a lot, developing a national research ethics policy for Trinidad and Tobago, which is a lot of work. So thank you so much, Magda, for joining us today. And just like on previous occasions, we have my colleagues Sara Carracedo and Ana Palmero, who will also be moderators. Sara Carracedo is here representing the National Health Institute in Peru, the OJIT office. She is also a PAHO consultant for research ethics matters, and Ana Palmero also works at the Ministry of Health in Argentina as part of the research office. This is going to be a dialogue, just as in previous sessions. Sara will be moderating the initial dialogue, and just like we did in previous sessions, we're going to have questions from the audience. And by the way, please share any questions that you can think of as the dialogue moves on, and then Anna will be moderating the Q&A session. So once again, thank you so much to our panelists Thank you so much to our participants and attendees. And without further ado, Sarah, the floor is yours.
Bien, buenas tardes. Muchas
Okay,
gracias
well,
por
good afternoon, and
acompañarnos a
thank you so much
este
for
tercer
joining
diálogo.
us in this third
Este tercer
dialogue.
diálogo está
This
dedicado al valor
third
social y
dialogue will
científico
focus
y consentimiento informado de las
on the social and
investigaciones
scientific
de
value
COVID
as
que
well
han
as
sido
informed
evaluadas
consent
en
for
diversos
COVID
comités.
research.
Para
And
empezar,
to
como
begin with,
Carla adelantó,
just like Carla
la
said,
descripción de los ensayos clínicos que se han venido realizando
the
en la
clinical
región,
trials that have
por
been taking
ejemplo,
place
se
in the
repiten.
region
Frente a esta situación y
have faced
en
different
rasgos
scenarios.
generales, me
So
gustaría
in general
empezar
terms, I would like
con
to
la
begin
pregunta sobre la
with a
calidad
question
científica
about
de
the
los
scientific
estudios que
quality
han
of the
revisado en
research
sus comités.
studies that you
¿Cómo
performed in your
calificarían la
committee. So
calidad
the question is,
científica de
how
los
would you
estudios en
rate
relación con el
the
volumen de
scientific quality of
investigaciones
your research
recibidas?
studies
Se han
compared to the
presentado, por
volume of
ejemplo, estudios similares,
information
misma
received? Have
intervención,
similar
misma
research studies
población,
been submitted to the same
o tal
group
vez
or around
estudios
the
con
same
muestras
topic, or
pequeñas, es
maybe
decir,
research
estudios
studies with
pequeños,
small
estudios con
samples,
diseños poco rigurosos,
or
y si es que los
less
han
than rigorous
recibido, ¿qué
standard
decisiones han
studies?
tomado
And if you
como
have
comités de
seen
ética?
that
No sé
as
si tal
members
vez,
of the
Sofía,
ethics committee, what kind
empezamos
of
por ti.
decisions have you made? So Sophia, would you like to begin? Okay, well, at the Clínica Alemana, we have not received like duplicate research studies because the teams are well coordinated, and they have to have authorization from the head of the department to prevent duplication. But we must acknowledge that a lot of descriptive research studies, not clinical trials, but the descriptive ones have a small samples because they just take a small number of patients that go to the hospital or that go see a doctor over a certain period of time. But I understand that the question whether studies present design issues, for example, no clear inclusion or exclusion criteria, or whether there's no clear explanation as to how they estimated the size of the sample. Well, if that's the case, the committee sends remarks, and we don't approve these studies until all these methodological issues have been resolved.
Bien, gracias, Sofía. No sé si
Thank you,
tal vez
Sofia.
otro quiere
I don't know if any of
contarnos la
our
experiencia desde sus
panelists
comités
would
de
like
ética.
to talk about their experience. I can go, says Leonardo. Is that okay, Sarah?
Sí, Leo.
Yes, go ahead.
Hello, I'll tell you a little bit about the ethics committee that I work with. I work in a public hospital in the city of Buenos Aires, so it is funded from the city government and based on the taxes paid by the residents of the city. So it has a lot of experience with research, and it does have an ethics committee that has been a pioneer in terms of clinical research. During the period of COVID-19, the last 7 months, 31 studies have come before our committee to be evaluated. And if you compare this with last year, I don't have the exact figures, but last year we saw about 1 or 2 new studies per month. So comparing this to last year, we have tripled our work during the pandemic with the same members of the committee, which has had a major impact and required a major effort from all the members of the committee. Among the studies that have been presented, most have been academic. Out of the 28 that we have evaluated, some we haven't evaluated because they didn't comply with the administrative requirements. But out of those 28, 24 were academic ones, and 4 were introduced by the pharmaceutical industry. And out of those 28, 18 were epidemiological description and 10 were interventions. Generally, we have found associations between different hospitals or hospitals and university or patients associations. So generally speaking, they have been well described and they had good methodologies. Perhaps the studies created by hospital researchers who are not as expert at this are the ones that had more challenges in terms of methodology. But I would like to take this opportunity to say that I'm also a member of the Central Ethics Research Committee of the Ministry of Health of Buenos Aires. And the role of that central committee is not just to study, but rather to organize the committees and collaborate. And in the Central Committee, we have received several studies that had significant methodological problems or that tried to pass themselves off as passive studies when they were really introducing drugs for different purposes. So in the city, we've received 6 or 7 studies that did have some methodological problems, but above all, it's a matter of the presentation. So they say this is a study, let's say phase 4, or a study with passive, but it's really a clinical trial introducing a drug for a different purpose. That was an ethical problem.
Bien, gracias Leo por los
Very well,
comentarios. No sé
thank
si
you,
tal vez
Leo, for those comments.
Magda o Sergio
I don't
quisieran
know whether
añadir algo
Magda
más.
or Sergio would like to add something.
Sure. I would like to provide some feedback. First, I want to get into some context of the Northwest Regional Health Authority. So in Trinidad, we actually have a parallel healthcare system. So one arm of it would be strictly for COVID-19 patients, and the other arm ensures continuity of care for patients. And as everyone is aware, being in healthcare, there are finite resources. So in comparison to Leo's experience, we've actually had a great decrease in the number of studies presented to the ethics committee for deliberation. The specific number of studies related to COVID-19 sent to the NWRG ethics committee have only been 3. One of those was a KAP, so it was just a knowledge, attitudes, and practices study. The other 2 were just simple medical audits regarding triage policy and adherence, as well as just a comparison of surgical volumes pre-COVID and during COVID. So in terms of that, I would say that the studies, they're basically descriptive, small sample sizes. Again, similar to Sophia's committee, what we see is that as an ethics committee, we provide feedback to the researchers. All of those studies that were presented in Northwest actually got conditional approval, and so they would have had to revise some of their submission before we granted approval. In terms of USC's studies that were presented, USC are more social based. It's an academic institution. And so those studies would be mixed method studies. And what we see coming out of those academic studies are that the students really have wide and broad objectives. And I'm not sure if that's trying to overcompensate for, the lack of COVID-19 research within the Caribbean or what they're trying to get from their study. So in terms of that, they would have had 4 studies, but actually one of those 4 studies was a multi-site study. And so not just based in Trinidad, but also some of the other Caribbean regions. And I guess we get into this later on, but in terms of reliance agreements for ethics review and ethics approval, that is something that researchers asking for approval from Trinidad to cover all of the other islands. So that's been my experience in terms of the study. So not a vast volume of studies. The quality is just simply, descriptive studies, no clinical trials at all.
Bien, gracias Magda por la intervención. Sergio, tal vez
Thank you
para
for those
finalizar y
remarks,
pasar a la
Magda.
otra
To wrap things up,
pregunta,
Sergio,
¿nos quieres
would you
contar la
like to say
experiencia de la
something
CONEP?
before we get on to the next question? Tell us what's happening at CONEP. Yes, of course. In Brazil, we have registered approximately 760 COVID studies. And this goes before ethics review and has been centralized in CONEP. So with this number of studies, we've seen it all. Everything that you asked about, we have seen at CONEP. Not very relevant studies, serious problems. There was a lack of coordination. In other words, most of them were independent studies. And this problem has been exacerbated by the fact that the ministry made resources available for these studies. In other words, there was competition to conduct studies, and as Carla very well showed in her introduction, we've had a lot of studies with hydroxychloroquine, and chloroquine more specifically because it's produced in Brazil. And also because some political groups defended that medicine fiercely at the beginning of the pandemic. And now that motivated people to study it, to study chloroquine. We've had a little bit of everything. In fact, there have even been, well, the biggest problem that we found with the studies that were not approved in Brazil was because a lack of justification. In other words, people had some ideas, but they were not able to provide a good justification in scientific terms or in any terms to justify the proposal. So unfortunately, some of the studies were not approved by CONEP and could not take place.
Bien, gracias. Gracias
Thank you,
por esas primeras
Sergio.
respuestas.
And I thank all of you for those initial
Ahora bien,
responses.
el volumen de la
Now
investigación
we
que
talk
se
about
está
the
realizando
volume of
desde el inicio de la
research
pandemia ha
underway since
sido
the start of the
impresionante,
pandemic has
no
been
solamente en la región,
impressive,
sino en todo el
not
mundo, ¿no?
only in our region, but
Y
throughout the
ello ha
world.
hecho que nueva
And
evidencia
this means
surja
that
de manera muy
new
rápida.
evidence is
¿Qué
coming out very
desafíos han
quickly.
tenido
So what
ustedes
are
como
the
miembros de comités de
challenges that you
ética
have faced
ante
as
los
members of
cambios
ethics
de la evidencia
committees,
científica que han
given
impactado en diversos
the
estudios en marcha?
volatility of
Tal
scientific
vez se han visto la
information
necesidad
and
de
studies
solicitar
that started in March? Perhaps
modificaciones
you needed to
o
request
incluso llegar
modifications
a
or
suspender o cancelar
even to
estudios.
suspend or cancel
Y
studies
finalmente,
that are
¿cuál creen
underway.
ustedes que debe
And
ser el
what
rol
do
de un
you
comité de
think
ética
the
frente a
role
estos
of an
escenarios,
ethics
ante
committee
estas
should be in light of
situaciones?
these scenarios or
Leo, no sé
situations?
si tal vez
Leo, perhaps we could
empezamos por
start
ti.
with you. All right. Everything has been so strange during this pandemic because information came in so quickly and through so many channels. For example, solidarity studies. When it came before the ethics committee, we'd already read everything. We all knew anything about it, but we had never come before the committee. And there had been experiences with vaccine studies in our city in which you would read in the newspapers the inclusion and exclusion criteria, and the committee, the ethics committee at the hospital hadn't even gotten the studies yet. So, and hydroxychloroquine, before the researcher continues that branch in the solidarity study, we all knew that that branch had to be cut off, but there wasn't even time to make the request. Everything came in at such breakneck speed. I'm concerned more about the future than the past. What's going to happen with these vaccination studies that are underway right now once an effective vaccine is available, and we have to use this and placebos? And when should we make the switch and stop thinking about a placebo as an ethical approach? But we haven't had major problems with this. Generally speaking, the scientific community has answered very quickly because the change has been worldwide, quick, and they've been shared. So they've come before the committees very quickly, and we haven't had to make any specific interventions.
Bien, gracias, Leo.
Thank you, Leo.
Magda, tal vez nos
Magda,
quieres contarle
perhaps you
tu experiencia.
could tell us about your experience.
Sure. So any ethics study that comes to the Northwest Regional Health Authority, the ethics committee wants to make sure that we're not unduly burdening the physicians and the clinical staff and the paraclinical staff at this time, because our health system, has limitations, significant limitations, especially in the midst of the COVID-19 pandemic. And while we have not had to request a modification or suspend or cancel a study, again, what we do is initially provide that feedback, what we need to see in terms of how the study needs to be adjusted before we actually grant approval. After granting approval, if it's a clinical study that's going to take place in sites, We direct the researcher to actually liaise with the medical director of that particular healthcare institution to ensure then the head of the department is aware and agrees and finds a feasible way to have the study. In terms of what is the role of the ethics committee in these situations where we have a lot of the evidence changing, I think what we need to do is really highlight the avoidance of duplication. And again, I go back to the reliance agreements because things are so quickly changing. Rapid yet rigorous review of these studies is imperative. And if we're having one proposal being deliberated by one ethics committee, then it shouldn't have to go to another ethics committee if it's multi-site, because then there's a delay, and then as the evidence changes, that study will also have to change. I believe firmly that the ethics committee, again, upholding the CIOM's guidelines, but also has to strengthen that rapid dissemination of technical guidance. And, you know, early on, PAHO, WHO issued a policy brief saying, you know, these are the guidelines related to research during disasters. And as ethics committee members, we're getting that information, but are we sharing that with the researchers so that they're aware? While we're improving the communication within our virtual platforms with our ethics committee, are we actually reaching out to researchers to say, this is the guidance and this is the technical information that you need? Also, in terms of the committee, regarding one of the multi-site studies that we had reviewed as an ethics committee for USC, we were thinking of actually assigning one member of the ethics committee to actually follow up directly with that researcher and that study so that we would have some continuous communication with them throughout this study. However, that study is still being adjusted before we grant approval. So again, strengthening that rapid dissemination of knowledge, improving communication, and trying to avoid that duplication, I think is key in terms of what the ethics committee needs to do in terms of rapidly evolving research and how do we address that.
Bien, gracias, Magda. Sofía, tal vez tú
Thank
nos
you,
quieres
Magda.
contar
Sophia,
cómo,
could you
cómo han
tell
sido
us a
los
little bit
desafíos que
about
han
the
tenido, que ha
challenges
tenido
that
la clínica
you have
alemana
faced
frente a esos cambios de la
in
evidencia
the
científica y los estudios que ya
Clínica
habían aprobado?
Alemana and the rapid change in evidence in the studies done? Well, I would say that in terms of the studies that have already been approved, the main changes has been request to make the registration and informed consent a little bit more flexible, moving from a physical on paper format to electronic formats, recordings or videos. If you look back, it's not only true of our clinic, but throughout the country, at many of the clinical centers, they began to use experimental therapies that had not been validated and outside of a scientific protocol. Just to give you an example, you might talk about remdesivir, the use of plasma, hydroxychloroquine, and later requests came in for ethical approval for retrospective analyses of experiences that had already been had, when you know that the scientific value is not going to be sufficient. And it has been hard to change the culture, to get people to at least use the OMEODI culture that requires ethical supervision and an appropriate process of informed consent. Generally speaking, at the level of the country, that protocol was not known, even though it had previously been studied through prior inspections. And linking all of this to the previous question, I have a positive view in that many people presented their research protocols, probably not with a very high scientific quality, but they did make the effort to adhere to these ideas that are out there, to have a protocol, to look for references to uphold their hypothesis, and that to use the data and be able to analyze it. And I believe that one area in which we've gained ground is to have the experience of submitting these protocols to an ethics committee. So while perhaps in this first round, a lot of it is not publishable research, I do think that we have made progress and added value in terms of this collective attitude of trying to record everything that is happening in order to generate new knowledge.
Gracias, Sofía.
Thank you,
Sergio,
Sophia.
y desde Brasil, ¿cómo es
Sergio,
que han enfrentado
in
los
Brazil,
cambios de
how
evidencia que han
have
podido
you
impactar
managed
en los estudios
changes
ya
in
aprobados?
evidence that could have an impact on approved studies? Well, it's all been a learning process, says Sergio. This has changed a lot since the first time we began to review protocols and up till today. So this was a really marked and significant change. Unfortunately, even though CONEP thinks that, yes, it would be very interesting for us to take the initiative to question researchers about the validity of continuing some studies. However, we have not been able to do this so far because since we have a very large number of protocols, it is very hard to track them down and speak to them one-on-one. We would have to have a very elaborate structure, and this has not yet been decided on. But I believe that, yes, it would be very interesting for some of the studies to be questioned because there are, in fact, some interventions that don't make sense anymore. However, what is happening is that in CONEP, we felt that you couldn't prove this, but many studies have been interrupted without CONEP even being aware of it. And so they may have not even let us know, and they interrupted the studies. For this reason, we need to make a major effort to work with the CONEP structure and find a way to determine the actual situation of each one of these studies. I believe that many of them have already been interrupted. However, we do not officially know. Officially, CONEP has not acknowledged any interruptions. I think that this is something we need to look at in the future. We need to start thinking about this right away because we need to bring this under control. And unfortunately, thus far, we have nothing. What we do have is that for some studies, the researchers told CONEP that they interrupted the studies. There's very few of them, but they are some. And for some of these, CONEP asked them to interrupt, but for matters of security or safety, not out of futility. I think that was just a couple of studies. So for the time being, we are a little bit behind in this in CONEP. We need to think of a better way to do this and intervene more in terms of finding those studies and questioning them, calling on them to reflect on this.
Sergio, por
Yes.
compartir la
Thank you,
experiencia
Sergio, for
de la CONEP.
sharing the experience of CONEP.
Finalmente, durante toda la emergencia, diversas medidas se tuvieron que adoptar para evitar, evidentemente, la propagación del virus. Y muchas de estas medidas han impactado en los procesos de consentimiento informado habituales, ¿no? Y muchos de estos procesos de consentimiento informado habituales parecen no ser idóneos para el contexto de la pandemia. ¿Cómo es que se han adaptado los procesos de consentimiento informado en el contexto de la pandemia desde sus comités? ¿Han permitido el consentimiento por representación? Y lo más importante, no sé si consideran que algunos de estos procesos han evidenciado que podrían quedarse más allá de la pandemia, ¿no? Para el futuro. Tal vez, Sergio, ya que estamos contigo, nos puedas contar cómo ha sido los procesos de consentimiento informado en Brasil.
About the informed consent process in Brazil. Well, personally speaking, I am very concerned about this. Why? Because I think that many of the studies, primarily those that have already started, were really a mixture of scientific studies with service components. In other words, they're conducting research within the health services delivery scenario, but it's almost a scenario of chaos.
So how did we know about that? Well, a lot of deviations from protocols, because whoever did the interventions were the nurses or the doctors that were dealing with serious patients, and and they were caring for critical state patients. So imagine what happened with the whole consent process. And that's why I said it's a big concern to me, because as we in the committee approved the formalization of the process, but now what happens in real life might be completely unknown to us. And like I said, this is a big concern to me, because that may have happened in this assistance-based environment. For example, what's the validity of having you give informed consent when we're talking about a patient, because these are not research participants, but rather patients, a patient that is extremely worried about their condition because, you know, he's suffering from an unknown disease. They're dealing with a disease that had never seen before. And we have no control over what's going on behind those doors. So CONEP was very flexible because we knew that we were dealing with this. So we enabled this consent by proxy. It had to be done remotely. It could not be done physically because the people responsible for the sick patients are prevented from entering the hospital or research centers, hospitals, whatever. So we had to become very flexible with that. But what happened in reality is completely unknown to us. Everything looks good, everything's approved, and like Dr. Salas said, we have alternative ways of doing things, you know, via video, internet, email, and some other tools. So we decided what to do on a case-by-case basis. But now, what happened in reality? That's $1 million question there. And honestly, if you ask me, I'm extremely worried about how things were done. I believe that consent is a process, not just a signature. So I believe that as such, the consent process was compromised, and we may not even be aware of that as at the ethics committee level. So yes, we did become more flexible, like I said. We understood that this was a pressing situation, and we did away with consent sometimes, depending on the case. But what actually happened, we don't know. May I say something? I have to say that I strongly agree with what Sergio just said, because we also had to become extremely flexible. We consider that to be what we needed to do at the time. But at the end of the day, we became flexible in somehow accounting for some kind of signature. But now, was that truly consent? Well, we have to understand the context in which all this happened. You know, this is an unknown disease. Everybody's scared. The patient is isolated with no family members, with no cell phones available, because at the beginning, we didn't even let patients bring their cell phones into the rooms. And once again, you know, the research studies in March or April were not the same as the ones in June, July, or the ones that we had towards the end of this process, or at least most recently. But anyway, the idea was to somehow, somewhat consented to treatment. But now, whether that can be considered informed consent, I don't know. Was that the right way of doing things? I believe so, given the situation at the time. Now, we can tweak things for the future. There's a lot to learn from this experience and how to do things better. But I remember one day we had a meeting with our researchers back in May, I think. But we had so many research studies coming to a committee that you had somehow the fantasy that as soon as the patient got into a hospital, there were 7 researchers with their informed consent. You know, one wanted blood for, you know, to see viral load, the other one what data for this other one, and, you know, all kinds of things. So basically we gathered our researchers as we told them how worried we were. We said, how are you going to do this? What can you consider a candidate for a research study? For example, if it's a study that's going to assess, you know, this thing, and you have a patient coming to, you know, floor 1. So, and there's a researcher there. Does that mean that that patient is a candidate? And what if the patient is sent to the 3rd floor? Is that person not a candidate? How are you going to communicate with the other researchers? So basically, a person that was on their own, isolated, away from the family, how can you consider that to be informed consent? It was tricky. All we did is to say, let's research. Today, we need to collect information. Now, what happened with informed consent? I don't know.
Bien, gracias. Antes de continuar con la misma pregunta, tal vez solamente un comentario. Creo que esta es una preocupación válida de ustedes y de sus comités, pero ¿no han habido alternativas? Es decir, esta incertidumbre todavía está. ¿Qué podríamos tal vez hacer para que los estudios que vienen no nos dejen también con esta preocupación? No sé si algún comentario sobre esto antes de continuar con la misma pregunta.
I don't know if you could speak to that before moving on to the next question. Sarah, I can answer right away. My answer is yes, we continue to not know a whole lot. We have to be honest. I believe that for the future, the informed consent process needs to be completely rethought. Because right now, in this emergency context, we saw a lot of failures, a lot of issues. And I don't believe that things have changed in a very positive way, at least not up until now.
Bien, gracias, Sergio. Gracias,
thank you, Sergio.
Por la honestidad.
I believe that we need to change a lot of things, especially thinking that COVID-19 will be the first of many emerging diseases. You know, we see that the epidemiological studies have been pointing to this for a long time. I know that at some point at the hospital, we thought about giving patients a hospital consent so that people know all the array of studies that were going to be performed. These were just ideas, nothing, you know, ended up happening. But you say, okay, maybe people can sign like a general concern, not to have a neurologist with their own concern and then their own consent. And then, you know, the hypertension technician and have them, you know, an informed consent for that, but rather a blanket consent. And then some other specific consents when there's a different type of intervention. We needed to come up with alternatives, but this was like a tsunami that came on us, a tsunami of, you know, cases and research studies as well. I believe that we need to find other ways. What we have today is good for times of peace, let's say,
Bien,
but
gracias,
not right now
Leo.
in this context.
Magda, Sofía, tal vez nos quieren contar cómo se han adaptado los procesos de consentimiento informado en sus países, en los estudios que han tenido la oportunidad de realizar.
Your studies, at least in the studies that you were able to review. I can start if you want, Sarah.
Sí, perfecto.
Well, we have seen the same kind of issues that my colleagues described, in the sense that the dermatologists, the hematologists, the oncologists, etc., everyone wanted to access to data or sample remnants. So we were able to achieve like a blanket consent for anything COVID related. So that way we could have access to data and samples without having each individual researcher go and ask for individual consent. But this was conditional upon approving the protocol by the committee. So basically we received the ethics review request for what we call a blanket or umbrella consent that includes all these smaller protocols or more narrow protocols, but I believe that we also have that lingering doubt about how is the informed consent actually happening in real life, because maybe we emphasize documenting the consent, whether on paper or a video or recording, than on what actually went behind that and what people understood from that, especially the vulnerable people. On the chat, there was a question about therapeutics that is highly related also to the difficulties of moving on with this informed consent process that can give us a peace of mind that when a participant is signing off or is agreeing, are doing so fully knowing what they are accepting or rejecting, depending on the case. Dr. Sofia,
Sí, por supuesto.
if I may, Sarah? Yes, of course. Currently, we have a tool that is called Makatsiar, which is a tool developed by psychologists whose purpose, which is validated in Spanish, but unfortunately not in Portuguese or English. It was developed in the US, so of course it isn't. But anyways, what they say is that this tool measures the competency, which goes above and beyond mere understanding. It's the competency that a person has to decide whether or not to participate in a research study. So talking a little bit about the future, maybe it would be better to use either this tool or a similar tool that could be developed in the future to assess more thoroughly what is actually happening in the field, on site, because we as research ethics committee worry a lot about, having that formal consent. But maybe the problem is not the formal consent, but rather what goes behind the consent.
Gracias,
Thank you.
Sergio.
Thank you,
Magda,
Sergio.
tal vez
Magda,
tú nos quieres dar tu perspectiva
maybe you
sobre
would like
estos
to
cambios en los
tell us
procesos
your point of
de
view about these
consentimiento
changes in informed
informado
consent
en el contexto de la pandemia.
processes in this pandemic context?
Sure, yes. So, what we did is we moved to virtual and we transitioned to different platforms where researchers could contact participants to be enrolled in the studies. But like Sergio mentioned, is it truly informed consent that way? Are we just trying to get a signature if it's through the phone or if it's online? Do we actually know? And it is a great concern. Yes, we want to generate knowledge quickly, but we also need to ensure that we maintain trust. And how do we know that that participant has that health literacy? And again, like you said, the competency and the understanding to really sign off on that. And so while we're an ethics committee and we want to take away those obstacles to conducting research, and some of those obstacles, such as, the social distancing and researchers having to wear PPE if they come in physically, and now we transition to virtual, we still have to have that balance between upholding our ethical principles and bringing scientific validity and rigorous research in that study. And we want to make sure that we actually have true informed consent. And I wanted to go back to the point that Sergio again made about the studies that were interrupted and that lack of formal notification to the ethics committee. Right now we're doing an audit of some of our research that has been conducted in the past, and truly some of them were never conducted till they were given approval, and they're telling us now, even years later, that that study was not conducted. And that is something that really has to be tightened up in the future. And so while we were not able to give any consent by proxy through our ethics committee, how will the processes stay in these COVID times for the future? I think we really need to explore how, in the midst of global pandemic, and again, this is a public emergency of international concern, but previous to this, there was Zika, there was Ebola, and like Dr. Leo said, it's going to come again with these disasters. How do we prepare ourselves to have ethics committees to really ensure that rigorous ethical studies are conducted in such demanding time, knowing that there's so much pressure on these researchers to generate knowledge quickly, yet we must also preserve our participants and our patients in these studies.
Bien, quiero antes ya de cerrar, tal vez
Okay,
volver
before
al
we
tema
conclude this
de
part,
si
I would
estos
like to go back to the
procesos
issue
de
of
consentimiento
whether
informado, o al
these
menos
informed
cómo
consent
se están
processes,
oficializando,
or at least the way
el
in which
consentimiento han venido
they
para quedarse.
become official, are ways
Porque,
that are here to
vamos, por más
stay.
que nos preocupen a
Because
todos
even though
cómo finalmente se
we're
lleva a
concerned
cabo el
about
proceso de
how
consentimiento
the
informado,
actual informed
es
consent
verdad que el
process
hecho
takes
de
place,
que ahora se
it's true
admiten
the fact
mecanismos
that
virtuales
now we
ha
accept, for example,
facilitado
virtual
que finalmente se
consents.
obtenga este consentimiento.
We were able to move to
¿Creen
that
que esto ha venido para
step.
quedarse? ¿Creen
So do you believe
que
that
tal
that
vez el
change is
papel ya
here
no
to
sea tan
stay? Do you
necesario en el
believe that the
futuro
paper
o
itself
que
will not
otras
be that
adaptaciones
necessary in the
se queden de
future,
ahora en adelante?
and that other, changes similar to these might come to stay? Well, first of all, we need to change our laws, and this goes beyond what we can do or what we think. Our regulatory agencies are not going to give in that easily to changes. They try to be more conservative on the one hand, but on the other hand, we have to, keep up with times. I would love to see more modern types of informed consent methods. At the end of the day, the researcher role is key in explaining, in letting people understand the difference between treatment and research mainly, and why it is being done. And that human interaction has to stay and has to improve. Sarah, if I may, I am highly critical of over-formalizing informed consent. I believe that this is protecting researchers and sponsors more so than the patients themselves. I don't believe that it makes it any clearer to the participants. So I believe that we kind of took away from the main original idea behind the informed consent. In Brazil, we have 40-page long consent forms. What is that good for? Can you imagine taking a 40-page long document to a COVID patient who's hospitalized? It is plain fantasy. It's just crazy. And it serves no purpose whatsoever other than showing to the ethics committee that they did their job. And at the end of the day, if something happens, they are able to protect the physician, the researcher, the hospital, the research study sponsor. But I find it terrifying that a sick person will be willing and able to read a 40-page long document. It's outrageous.
Gracias, Sergio, por esa visión
Thank you,
crítica
Sergio, for
del
being
consentimiento informado.
hypercritical of the
Magda, Sofía,
informed
tal vez
consent.
quieran
I don't know
agregar
if
algo
Magda or
ustedes
Sophia, you would like
para
to add
culminar.
anything to conclude this topic? Yeah, I believe that, Sarah, in your question, what's implicit is overvalue the signature of the informed consent per se, and giving more weight to the signature than to the informed consent process. Like you said, 40-page long documents with a language that oftentimes the ethics committee members have a hard time reading and understanding. That's completely useless. It would be more interesting to see how the researcher can talk with the potential subject of the study to translate in plain terms the details of what it means to be part of a research study, and to clearly make a difference between what being part of the study is and what being a patient is. Because sometimes the physician becomes the researcher and the patient becomes the subject of the research study, and that makes it highly confusing for everyone.
Magda, tal vez para finalizar, ¿te gustaría añadir algo?
Magda, perhaps you could say something to wrap up this question.
Sure. Again, while we move to virtual, I just wanted to support the point by Sophia. You know, one of the ethical standards is fair and voluntary participation. So how do we ensure that that participant understands and has competency? Again, if it's just one of those check boxes that has to be completed. And while we would have transitioned to virtual, it was through the phone or it was through just an online informed consent process. So there was that lack of face-to-face interaction. And so perhaps when we consider virtual and informed consent, it could now at least be a virtual consent process where you're seeing me and I'm seeing you as not a participant, but somebody who has a choice whether they want to participate in the study, and that study is separate and apart from their treatment. And this is critical moving forward, that we put that patient as the priority here, and they understand and they have the competency to have that free and voluntary participation in the study.
Bien, gracias. Muchas gracias
Very
a todos
good.
por,
Thank you.
por
And I thank
su
all of
participación,
you
por
for your
respondernos estas
participation
preguntas y
and
sobre
for
todo por ser tan
answering these
críticos
questions,
y
and above all
sinceros
for being
frente
so critical
a
and
estas cuestiones que
honest
a ustedes y a muchos
in
miembros de
response to
comités de la
these things that
región
you and so
les preocupa.
many
Creo que es hora de pasar
committees in
a
the
las
region
preguntas y a la
have to deal with.
discusión
I think now
con
we
el
can go
público
on to the question and discussion with
Ana,
the public.
te paso la
And
palabra
we'll
para que te
hear from
encargues tú de esta
Anna.
parte.
We'll let Anna be in charge
Gracias.
of this section. Thank you, everyone.
Gracias, Sara. Gracias a todos los panelistas. Muy
Thank you, Sarah, and I thank all of the panelists. These have been very good remarks. Okay, now I'm going to go on to the questions from the audience. The first one is for Leo. It's what's the name of your cat? His name is Silvio Rodriguez, and he's an expert in medical ethics. So yeah, we'd like to hear his opinion. We have a question here from Hector Garcia. And that's the question of the criteria that you followed to assess the social value of projects related to COVID-19, thinking of the social value, the benefits, promotion of health for the participants, and at this time of so much uncertainty, to be able to have an objective analysis. I know it's very complex, and we'd like to hear your opinion on this.
Sergio, ¿quieres comenzar tú?
Sergio, would you like to start? Yes, okay. Assessing the social value of an investigation during a health emergency is pretty straightforward. It's all very valuable. The problem is how you can accomplish what you want to do, get the answer you need, and what can you do in order to get the answers. So I think that the intrinsic value of the proposal, generally speaking, is very good and very favorable. But what's happening, the biggest problem is related to the way that they do this. So we have to have at least enough foundation for the potential benefit to be evaluated. You know, otherwise,
La facilidad que tenemos es porque no tenemos tratamiento.
We don't have treatment. There isn't anything that works yet. So this research is supposed to facilitate this, but the intrinsic social value is always favorable. But what's happening is that you have to have a well-founded proposal to justify the intervention. And that is what I think.
Coincido con Sergio.
I agree with Sergio. Now, in terms of the social value, anything would help. And I think, you know, a kitchen recipe would help. In other words, it's not the same thing that we thought in March as now. For example, in our committee, we received a study on vitamin D versus placebo a couple of months ago. Maybe back in March it would have been approved because we didn't know what to say about it. Now we know that that's not enough. So I think that we could have put together a problem or a dilemma in terms of vaccines if we knew that our national governments did not have a direct relationship with the sponsors of studies. So I don't know if it would have been ethical to admit that you could approve a laboratory vaccine when the governments didn't have access to vaccines, but this did not occur. And now I think that in any case, we could apply the criteria of social value in terms of restricting some studies that don't have a valid response. We can't lose time with people in that context. But everything at that time had social value. Any would have been valuable. Perhaps the most difficult thing was to reconcile social value with scientific value, particularly at the beginning, because in fact there wasn't any prior knowledge about what therapy might work, and everything could eventually have some level of usefulness and high social value. I think that we were weaker in the scientific value of some of the studies. In fact, and I don't know whether there will be enough time to discuss something related to vaccinations, or which I think vaccines, which Leo mentioned, what's happening with the clinical trials of vaccines. If during this process we approve or register any vaccine and we're still doing placebo controlled studies, how can we have this? This would be super relevant.
Magda, ¿quieres agregar algo?
Magda, would you like to add something?
Yes, I want to support what Sophia said about the social value versus the scientific validity, because again, yes, at the start, we're looking at what do we know and how it adds to the evidence base. When you're looking at the Caribbean, where we know we have limited research, scientific research, and now we have a new disease and a pandemic at that, we really don't want to block researchers. And so I think from that extent, ethics committees are kind of pressured in a way to approve or at least guide these researchers to, you know, conduct their research and kind of take away the obstacles, because yes, we do want to encourage research, and especially in our setting where there's so limited research studies compared to the global studies, we don't want to say, well, you're not going to add to the evidence base because it's something so new and so novel. It will add to the evidence base. But again, is it valid? Is it scientific? And will it really provide the information that we need versus the societal value of it?
Gracias, Magda. Creo que un poco también la cuestión de la incertidumbre.
Thank you, Magda. I think we also have the issue of the uncertainty that we had at the beginning of the pandemic with over time and the evidence that was coming out. This is also something that's very important throughout this health emergency, which is to have the supervision and these studies. I'll take advantage of this opportunity to tell you all that these documents came out yesterday. Someone alluded to this, and perhaps it's gotten more complicated. I think that monitoring is a problem in the region. There's a lack of resources to do this, particularly in the public institutions. But how do you think that we should establish some criteria when we're thinking about this for the future in order to have monitoring from the beginning? It might be something that, okay, we're facing a pandemic and everything goes, anything goes. I don't know who wants to answer this. You're talking about follow-up, Anna? I would say that it is hard for the committees to have capacity to follow up on all the protocols that they've reviewed. My suggestion is to look at the protocols in which the risk-benefit balance is smaller, in which the participants are a more vulnerable population. So we should focus follow up or monitoring on protocols in which it's more critical to do so. Another thing to discuss in the future was maybe putting together special teams. I think the same things happen to all of us. We had 120 COVID patients in the hospital, and we're running out of beds, and everyone was extremely stressed, tired, underslept, and we had tripled our workload, and no one stopped working through all of this. So above all of this, have special requirements? I think it's impossible. If we're looking at a tool that was useful for normal situations, for a very exceptional situation. So I don't know if our committees, we had to look at how we're put together. It's by the same clinical practitioners working with the patients. I think we maybe need a special committee for that, designed specifically for this kind of situation.
Gracias, Leo.
Thank you, Leo. And going back to this topic, particularly from the countries that have had a lot of research, such as Brazil and Argentina, we see the need that Sergio pointed out for coordination. There's been a lack of coordination between the research studies, and a lot of similar studies and situations. They were affected by these studies. How do you think, looking to the future, that we could have coordination within your committees? Should you take on a special role? Should there be more from the government? How do you perceive that coordination in the future?
Si quieres, Ana, yo puedo contar una experiencia.
If you'd like, Ana, I could tell you about an experience that we had in Chile, or that we're still having now, related to trying to coordinate ourselves better for the vaccine protocols. There are 4 candidate vaccines that are being reviewed, some by 7 different committees, and we made an attempt to have some homogeneity in the ethics evaluation. And for this purpose, we put together an ad hoc committee under the ministry supervision to issue general guidelines so that the local committees could adapt this to their own reality and then follow the approval and monitoring process. It has not been easy at all, because since we often have time constraints and the protocols are already under review when they put together the committee, there was some concern by the local committees that there be an entity supervising or issuing guidelines vis-a-vis what they were doing. But we still have been able to make progress in identifying certain common themes. So I think that it would be good to think about getting the committees to work to network more, because we all face the same problems. And when you share your deliberations with other committees facing different situations, I think that we empower our review process. So I'd like to see us make progress along those lines without taking away the autonomy of the local committees that are ultimately responsible.
Nosotros en la ciudad de Buenos Aires hicimos.
In the city of Buenos Aires, we say that we designed a special procedure for this, and perhaps this was when we saw, for example, that a multi-center study was coming in for a vaccine. The Central Committee of the city convened a meeting with all of the committees that would be involved in the study, to establish some common understanding and to ask the same questions, because another complaint of the sponsors and the study promoters is that each committee asks its own questions, and that really takes a lot of time when we don't have time to lose. So the prior discussion among committees sharing the same studies really sped up, really expedited the Q&A. And we were able to move forward much more quickly. So that was good. So generally, we have to have that kind of thing in the future for special situations.
Gracias, Leo. Ahora pasando a los estudios en particular.
Thank you, Leo. Going on to the studies in particular, we had appointed some people to do adaptive studies like solidarity. What how have you assessed these kinds of studies, and how can there be changes?
Cambios de drogas, cambios de ramas, tenían experiencias previas.
So, did you have prior experience? How did you handle those assessments? Well, in Brazil, we did not have these adapting studies, but I believe that they're acceptable. What happened is that in Brazil, we always said that for every change that we need, they are going to include in the study, they need to let the CONEP know and have it approved. It's not automatic, but it works. I believe that this is progress, especially in this context of, emergency and all the uncertainty around this disease. I believe it's that adapting studies are good, and CONEP did not reject this per se. I don't believe that was an issue. Thank you, Sergio. Has anyone else have adaptive studies? Well, we did not have a lot of experience, honestly. We have had adaptive studies, but we learned a lot more about them quite recently. We need to understand them better, have better information, and clearly that's what's coming because it reduces times, and it prevents further complexities with the studies. So in a sense, it protects us more. But we did not have a lot of experience, going back to your question at the beginning of the pandemic. We have an adaptive protocol project. I believe a lot of the challenges that we, the ethics committees, have is being up to date in these new protocols to step away from the conventional ways of doing things. And what has been useful is to invite researchers. When the researchers are highly trained, they also help us learn, or, resort to committee members that have experience in adaptive trials so we can all tweak them to our new reality. Here we have a comment from Fernando that says that one of the big issues around ethics is that it has been reactive rather than proactive or preventative. I believe that that's in, maybe in other words, what you have said. So what proactive actions do you think you can take now? Maybe not in the middle of the pandemic, but maybe for the future. Magda?
Yeah, I kind of agree because, previously there were all of these guidelines related to technical guidance in conducting research during pandemics and disasters. And so the information was there, it was just for the ethics committee to quickly utilize it and disseminate it, not just to the members, but also to the researchers. And again, we see the limitations of ethics committees. While I'm trying to get responses as a secretary of ethics committee, it's hard for some of the studies to be expedited because you really need the feedback. And I know Sergio would have had that experience with ProEthos. So we have these platforms that are virtual that allow for rapid expedited review, allow for better communication of ethics committees, better communication between the committee and the researchers. Yet we have waited. Why didn't we implement this before? So now we're in the midst of a disaster in that sense, and now we have to kind of say, well, what do we need to do? Our ethics committee has actually co-opted members, technical members from PAHO, in times where we need that expert guidance. And so I think that's something that ethics committees need to do. We start to have to rely more on each other and find out where the technical expertise lies, and we have to consolidate resources. So I want to go back to what you were saying about, you know, ministries of health or other regulatory authorities actually providing the support for the functions of the ethics committees. While yes, the committee remains autonomous, the regulatory authorities can really help us in terms of compliance from researchers and can help in informing some of the monitoring and follow-up of research. Because if you look at Leo's experience of, you know, the larger number of research studies coming this year with the same number of ethics committees, how do they sustain that? And so we need to really start taking more action. We need to look at the lessons learned from our experience and start to really evolve our committees to meet the growing demands required.
Gracias, Magda. ¿Alguien quiere agregar algo más?
Thank you, Magda. Would anyone else like to add anything? I would say that at least in Chile, one of the most pressing demands on the ethical committees, on the ethics committees that work in public hospitals is that they feel neglected by health authorities. Not only are they not paid well enough, but also they don't always have a protected time, you know, to do their job. And during the pandemic, all committees went from having a monthly meeting to having basically a weekly meeting, which means a lot more time devoted to their work. But I believe that in general, their response was accurate. But in my idea, we need more institutional support, especially for the committees that operate in public hospitals, in public settings. I fully agree, Sophia. And now, moving on to the issue of informed consent, you talked about how you had to become more flexible and adopt new tools. And actually, these tools existed already. We could have used them before. Like Leonardo said, hopefully we will be able to keep using these. And Juan Pablo says that he believes that this health emergency situation revealed what the reality was in an emergency situation when you cannot get an informed consent from a patient because they are in the emergency room. And there's other questions with informed consent. Clearly, they were not talking about a blanket informed consent, but something different. Sophia, you had talked about a blanket consent. Can you talk a little bit more about that? For the Clínica Alemana, what we said that was that when we had a suspected COVID case, to give the patient, together with many other papers, to give him a broad informed consent authorizing the use of his or her remaining samples or data for the purposes of research related to COVID. So, but there would be somebody, an authority protecting the samples, protecting confidentiality, and that each protocol was going to be previously approved by the ethics committee. So the idea was to kind of making it easier to deal with this recurrent issue that our researchers brought up, that is to say, access without consent to mainly the patient's charts. So we have authorized those consents to the extent that they can guarantee that data are extracted in an anonymous way. But you know that sometimes that's not the case because you need to have access to open source information on the patient's chart. And I believe that that's an issue. So to the extent that our databases become better, it will be easier to have access to anonymous data. But for the time being, our proposal is for the use of remaining samples to have a blanket consent for COVID research purposes only. Thank you, Sophia. Another comment has to do with the role of the media and social media in general, and how communication on research studies is taking place through the media and the social media, which was also a challenge for the ethics committee because we had to, weigh in the number of messages and communications that went out. So do you believe that this should be here to stay as a way to communicate and inform the community? How do you think this is going to look like in the future? In general terms, I have been extremely worried about how irresponsible the media has been in dealing with the pandemic. Right now, every single TV show talks about vaccines. They talk about adenovirus as if it was, the Master Chef show, as if, this sauce is better than the next sauce. It's ridiculous. And the same happened with plasma research studies. The media inflate the information on plasma and make it look like it's the cure against COVID. So patients would demand plasma at the hospitals when we knew it was just a research protocol. And, it ended up proving to be quite weak in treating patients, but it was crazy. The media should be much more responsible in terms of having scientific journalists, which is not usually the case. We don't normally have scientific journalists, and we need a big code of ethics for the media when they have to deal with cover health issues. Today, they are more an issue than a solution, and we need to take this opportunity to turn the media into allies. But it will be very difficult because of the number of, hidden forces that are, pulling and pushing behind these big media. I'm sorry. Sophia, go ahead. I would say that there's also a role that the academia should play, and scientific experts and bioethics experts, because we need to make ourselves available to talk with the press, to share information, to inform the people. And I believe that there are a lot of scientific journalists that are well prepared, that want to do their job seriously. And oftentimes I heard about news because they send me the link to me before making it public. So we need to consider ourselves allies, and rather than opposing the mediocre media that some yellow press media outlets make available to the public, to rather identify these serious scientific journalists to improve information, because there is miscommunication. I don't know what happens in your countries, but in our countries, over 40% of the people say they do not want to take the vaccine if a vaccine becomes available, which is kind of similar of what other countries are seeing. And we need to fight misinformation in the field where scientific information is played on, not in the academia, because we don't need to preach to the choir. We need to make sure that the general public is aware of what the scientific bases are. I agree with Leonardo and with Dr. Salas. In Brazil, the whole issue has been a big mess. A female journalist interviewed me a few days ago, and she asked me about talking about vaccine. Do you believe that there is misinformation around vaccines? And I said, no, there's over-information, but misinformation, poor quality information, which is even worse than having no information at all. So we're dealing with a serious issue here. And some people in the academia, I don't know why, but started posting videos on the internet with information that was just what their thoughts were. They did not have scientific basis. And I think that a lot of these things happen because of the lack of knowledge that we had about this disease. So a lot of people took advantage of this void to just, come up with ideas, make a video, and because this person came from the academia or was a doctor, that those videos went viral and were received, how can I say this, widely, and it got into people's heads. So I believe this has been the worst, the worst aspect of the pandemic, misinformation, and how many lives has this kind of behavior taken. I believe that it literally killed people. So it is a very serious issue to see how the media handle the situation. Like Dr. Salas said, yellow press cells here in the United States, they also say that they had miraculously found a solution. And unfortunately, science did not say that. Science is realistic. Just because we are in a hurry, science is not going to, magically speed things up and skip steps. So that in Brazil was a huge mess. Thank you, Sergio. Magda, anything you would like to add?
Again, I think we really need to address the concern of misinformation in a holistic manner. In Trinidad, we try to correct that through channeling the public to the website of the Ministry of Health and the social media platforms of the Ministry of Health. But again, we had that continuous misinformation, not just being spread in the media, but also through social media platforms such as WhatsApp messaging. And you would see this like, one of the panelists said, actual members of the scientific community spreading misinformation. And because it was so new and people had so many questions, they were more taken in than they would have been for a previous disease that a lot more information would be out there about. And so now we have this vaccine hesitancy where we hadn't seen it before. Trinidad has a really high uptake of vaccinations and immunizations. So now even for something as simple as seasonal influenza, we have vaccine hesitancy. So if we have that for something that is standard annually, what will happen when the COVID vaccine becomes available? And so we have come to the point where we have been several times in the past with public health, and that is the mistrust of the public related to public health research. And how do we address this? And it's something that we really need to take seriously as members of healthcare, as scientists. We need to have some proactive needs to address this. I'm not too sure of the answer myself, but it is a huge challenge. And now we're going to see the repercussions of this misinformation.
Gracias, Magda.
Thank you, Magda. And this goes hand in hand with politics, which is also sometimes an issue. So from your ethics committees, you have not only misinformation from the media, but also political pressure. Sergio was saying that Brazil was putting a lot of pressure on hydroxychloroquine. In Argentina, we also see how plasma was promoted as the magical cure against COVID. So how do you think we should handle this whole issue of science and politics? Just one thing, Anna, there was no pressure from the government on CONEP for hydroxychloroquine, but everybody knows that the government of Brazil and some specific representatives from the government, from the Brazilian administration, strongly advocated for the use of chloroquine. And if people gave interview with the little box of hydrochloroquine, so that is subliminal pressure. But we did not receive direct pressure to approve a certain trial or to speed things up. That has not happened. I have to clarify. CONEP has not suffered any kind of direct pressure, at least that, got to us, the members. And, we are the ones that do the reviews, so we should have heard about it. So let's make it clear. The Brazilian administration has not put pressure on Connect at all.
Fondo de la pregunta de
I think the background of Anna's question is a global perception that there is pressure from the countries to promote its own, well, its own vaccine in this case, to win the race with their neighboring countries' vaccine. This, in my view, has perhaps frivolously led to emergency approvals of vaccines when the clinical trials have not been completed. And I do believe that there is politics behind this. It's not just political, but also economic, and I think that politics should not mix with science. I fully agree, Doctor, fully agree. I think that it's very hard to think of science without politics or political science, because science implies something of politics in terms of where you invest money, in what way, what do you prioritize, and what are the agendas above all. And for this reason, you need to have political power. Who puts together the health agenda of a country? It's clearly a political position. I think that we have all suffered extensively with the interest and need of politics to provide an answer to the COVID crisis. And we have found, for example, that the first image we have of solidarity was through the media with the Minister of Health of our country talking about a study. The first photo we got of a vaccine was with the president of Pfizer, with the president of Argentina, like with many other countries. It's not to single out my country, but and now the centers or access to a vaccine is determined by political access for researchers and the number of patients that they can recruit. I think that the applications that were submitted, they focused on that a lot. I think that politics has been very strong in terms of the control measures. Argentina is a country that was prepared for many things. We have AMAT, a regulatory agency, and consolidated ethics committee. However, we have had to withstand the onslaught of politics. And that's separate of this. I think if the question is what we can do in the future, we have to keep doing things right and remain fast on the ethical path, because those forces are so foreign to us. These are tsunamis that wash over us. Well, we have to be firm and not give in to this pressure. I think we'll be able to do things the right way. That's what our future is. We can't force the media to have scientific reporters. What we have to do is remain steadfast and not give in to pressure. And I do think that we can do that. It is within our control. Thank you. Now, going back to informed consent, here we're being asked, have your countries approved any alterations to this? Or what decisions have you made as committees in terms of any adaptations to the regulations? In our case, it's been more of adaptations than specific regulations in these agreements. A few things were tweaked. For example, requiring some studies to have insurance. In other words, the government provided a backing for this, like in the case of plasma, but we didn't have special regulations designed for the pandemic, nor has anything been permanently changed. The ministerial decrees always clarify during the course of the pandemic in order to limit the field of action of that exception. Same is true of Brazil. We have not had any special regulations. We simply adapted them and looked at it on a case-by-case basis. We did not create any new rules specifically because having to do with informed consent in the context of the pandemic. In Chile, we made recommendations that, first of all, were prioritize all clinical COVID studies above non-COVID studies. Secondly, and the full-blown pandemic, we recommended from the Ministry of Health that we not begin any new non-COVID clinical trials, and we made more flexible and adapted the health aspects so that any subjects that were involved in clinical trials underway could have access to drugs or controls without having to go to a treatment center. And also specific recommendations to adapt informed consent for COVID times, because our law always talks about a piece of paper signed with a witness and et cetera, which became totally unfeasible. Magda, tell us about how the situation has been in your country.
Sure, again, we haven't changed our protocol from our NWRG Ethics Committee. We just went more virtual. We were already halfway virtual, and we improved the expedition of any proposals that were for deliberation in the committee. Again, we do want to ensure that the challenges related to COVID-19 research in Trinidad are addressed, and we help the researchers in that manner. Nationally, the bioethics policy is still in draft, and there are no special regulatory authority right now for national guidelines related to informed consent. And really, that's what we need. Yes, the ethics committees have autonomy, but we need that higher level advocacy to really streamline the process and improve informed consent during pandemics.
Gracias, Magda. Aquí una última pregunta, que ya estamos llegando a la hora.
Thank you, Magda. Last question, since time is running out. Given the possibility for a situation such as this one of the pandemic, could we think about informed consent that might be a little bit more simple or straightforward globally for this kind of situation, and adapt this to the unique situation, but to already have an informed consent, general informed consent protocol? I think that that's a feasible solution as long as we're talking about data, more epidemiological data, but specific interventions, no. Those do require their complete process. I agree with Leo. I don't have anything to add. He's right.
Magda, ¿quieres agregar algo?
Magda, would you like to add something?
Yeah, I support Leo in that regard as well. What I was thinking is that similar in the United States, where on the driver's license, they actually state whether you can be an organ donor or not. Maybe it can be some kind of database like that, like, yes, you release your medical record information up front, but in terms of intervention, I still think it's highly critical that researchers have that face-to-face interaction with participants.
Bueno, muchísimas gracias a todos por sus intervenciones.
Thank you very much to everyone for your remarks. This has been a very interesting discussion, and I will now give the floor back to Carla for wrap-up, and I thank you all once again. A million thanks to our panelists and to all of the participants. More than 150 people have been actively participating with questions, comments, suggestions. I think that just to illustrate Magda's suggestion at the end in terms of the ID card as an organ donor, how could we do something equivalent to this to show that one is genuinely willing to participate in at least certain types of studies? Let's say, just to say that your data could be used in research. I think that it's clear to all of us that aside from the unique situation of the pandemic, We are at a juncture that allows us to think about doing things differently and better in the future. In one of the previous dialogues, I said that I think it would have taken us 20 years to reach clarity on some things. When now over 4 months, we've all reached agreement on these. There are many recurring themes in this dialogue. At several points of the conversation, several of you have stressed the need to go back to the substance and to stop complicating things with matters of form. For example, the substance of an informed consent process, not the papers and formalities. How can we be capable of honing in on what's important, not just when we review the protocol, but also in the implementation of the protocol? I think, and I'm very pleased that our next session and our next dialogue that is planned for November 24th is precisely with the researchers, because I think that we could tear our brains out thinking of options, but if we don't work hand in hand with the researchers, then we're going to continue to have problems. And there is no way to supervise each informed consent process itself. Our best way to ensure that a research project or study is ethical is by, what word can we use better than brainwash? All of us are absolutely convinced of the importance of conducting a study in an ethical way. And we have trained our researchers in this from the outset. And this yields a better dialogue. Another point that was raised, as ethics committees, we are getting informed in this on a daily basis. How are we making sure that the researchers are too? What are our channels of communication? Do we need to consolidate these? Of course, some of you have mentioned this already in the dialogue, and that's communication with the public, with society. And I think that there are several lines of action that are clear in terms of the work that we need to do, and also some old lines of action. Some are still pending. More institutional support for the research ethics committees. So I think that the time has come, as we are all noting the importance of research and the importance of ensuring that research is ethical. I think that we're in a better position than we were before to ensure that ethics committees have the support that they need for carrying out this very delicate work and doing so in timely fashion. I think that another cross-cutting important line to stress is how you move from the issues of our dialogue and the ethics of research to public health ethics. Refusing vaccination, getting the population to accept public health interventions. I think that normally when we talk about public health ethics, we don't do that jump back to research. And now, within the specific context of vaccines, and I'm referring to vaccines in general, not simply COVID vaccines, we need to think of affirming up that link. This is ethical research, that we have to get the population to trust it, to be informed on it, to know that this is done in an ethical way. These are the studies that generate trust in the results, in the vaccines that they may yield. It seems to me that there are several areas in which we have a lot of work to do. These are topics that perhaps we should be thinking out better. We can see how can a future, How can we handle things better in a future pandemic? You might say, well, we tried to do this, but there's so much work. Is there a different way to cut up the pie to make sure that research is ethical? We're going to continue these dialogues because we're going to continue to think of these things. I think that while many of you, through your institutions, through your positions in your country, and within your jurisdictions, have taken some measures very quickly, but not all of the committees or all of the jurisdictions see the same urgency of action. So the lessons that you share are essential for other committees and other jurisdictions that haven't seen this huge volume of research that, for example, Brazil has seen. So I thank you all very much. Thank you, Magda, Sofia, Sergio, and Leo. Thank you very much, Anna and Sarah. Thank you very much to our entire team behind the scenes, making sure that these sessions will come off smoothly. And thank you very much to our interpreters who allow us to have a truly Latin American and Caribbean dialogue so that we can join efforts in this conversation. I hope that you have a very nice afternoon. If you have not yet done so, I invite you to sign up to PAHO's ethics and research list, and we can invite you to our pending dialogues for November 24th, December 1st, and December 7th, and we will be sending you the invitations through our list. Thank you very much, and a good afternoon.